We are beginning the recording of the slides from now. So today we will be going on to the chronic organic reactions. We saw the acute organic reactions last lecture. This lecture will concentrate on the chronic reactions. And as in acute organic reactions, we have uh, different synonyms or terms that are used depending on the situation, needs, the country, and so on. A common term that's used, particularly in Jaffna, is chronic confusional state, because characteristically the patient is confused. They are not able to relate to the reality as normal people, but they may not be completely disoriented as in acute organic reactions. The disturbances may be more to do with the memory and their functioning capacity and so on. And some of their responses and reactions may be delayed or even absent. Sometimes in United States, for example, they use the term chronic brain syndrome because again, it is a reflection of an affection of the brain, particularly gross overall functioning of the brain is being gradually insidiously affected. So they call it a chronic brain syndrome or psychosis. And we like to have a clinical picture in our mind, and we can think of a example, a typical example, a prototype, and the one that is usually uh, described is dementia, which we are familiar with and which may be a typical example of a chronic organic reaction. Maybe a little extreme, but still a good example. Now, as in acute organic reaction, it's very interesting that the clinical pattern that we see, the syndrome, is very similar, despite having a wide variety of etiological causes that we can describe. The final common pathway seems to be very similar. There may be some variation, particularly depending on some focal signs. So, if the uh, etiology is related to a brain disease that affects certain areas of the brain, functioning in those areas may be impaired, uh, giving signs, symptoms related to that, say, like the frontal lobe or the temporal lobe, or there may be a paralysis or weakness on one side of the body if one part of the brain is initially affected and then it spreads, or the pressure causes the whole brain to start dysfunctioning. So there may be what we call focal accentuation. But the final clinical pathway seems to be very similar. Now, when we look at the pathology, what is really happening, uh, the final common pathway involves diffuse, widespread structural damage, and usually it's a gradual degenerative process that we are seeing in the brain. So, it's reflected in brain atrophy. And clinical picture that we see is a progression, gradual deterioration in various functions of the brain like memory, intellect, the personality, and also the behavior patterns, their social and ethical etiquette, their what is acceptable in society. There may be some laxity, there may be some disinhibition, and most of these changes are of a progressive nature. Unfortunately, it's a chronic, deteriorating, progressive condition. As I mentioned earlier, some conditions may start as a focal uh, lesion, can be in one of the lobes, frontal or temporal lobe, or it may be in the deeper structures, some of the diencyclic structures, or in some of the nuclei, and that may dominate the picture at the start. Uh, but as the condition progresses, the whole brain is affected. So the final picture may be very similar. Now, in contrast to the usual, particularly in dementia, the progression, downhill progression, you may get a static picture. You may get, for example, some of the treatable causes. If you treat, uh, but already there is some damage, then that you may get a continue, like in those days when we have syphilis and you treat with penicillin and so on, you may arrest the process. But what's already been damaged may remain. Uh, some conditions we may see some gradual improvement, like after head injury, cerebrovascular accidents, where there may be absorption of the blood, there may be some repair and improvement. So the person may gradually improve over months or even years. So there is always some hope in these some of these conditions, and it's very important to be able to detect those conditions that can be addressed and treated, so that we can either arrest the process or they can actually recover. So it's not a bleak and with poor prognosis. There are conditions that can be treated uh, if recognized, and some, as I mentioned, if you can treat it, uh, you can completely sometimes even reverse the process if the damage is not permanent. So good examples are myxedema, B12 deficiency, some of the benign tumors. If it is removed, then the patient may make a good full recovery. Now, just to repeat or go back over some things that I've been already saying, when we try to understand what's going on, try to look at the underlying pathophysiology, we have been saying that the disease of the brain uh, can be either generalized, affecting the whole brain, which is usually the final end product, or it can start as a focal condition like a tumor or an abscess or a disease process that affects certain parts of the brain. And so you get focal signs because of the area, the location. And then secondarily, as if the condition is not treated and it progressively becomes worse or grows, secondarily you get the generalized effects. So invariably, whatever, if whether it's focal or generalized, you get a final affection, the whole brain. The whole brain is affected. So you get a kind of uh, diffuse, widespread degeneration of the whole brain. And there are structural changes in, even at the neuronal level. Some neurons may actually be killed, they may die, you may get tissue formation and so on. And finally, what you see is an atrophy of the brain shrinks. So as I mentioned again, the clinical picture is very similar when you reach this stage, not at the focal sign, but when you get the generalized degeneration, you get a progressive deterioration in memory, intellect, personality, and behavior, and it can end in death. Particularly in dementia, we say the condition can end in death. Now, again, like in acute organic reaction, I would like to quickly go through some of the etiological factors, just to show the wide uh, clinical the causes, the background factors, and to some extent, it is important to know to also to be treated properly. Some are reversible, some can be treated appropriately if the etiology is known, and also helps us to understand various processes that are going on in the brain, and maybe in the future they can design proper, adequate, appropriate treatment with all these new developments in stem cell and implantations and so on, we may be able to treat many of the conditions that we now find untreatable. So generally, when we look at the dementias per se, that is the main focus of the chronic conditions or the common condition is dementia, and it's traditional to divide them into senile and pre-senile, and having the age again somewhat arbitrary at 65 years. So if the condition starts after 65, we call it senile, and if it's before 65, we call it pre-senile. Although the real cutoff, that line is not is in a sense arbitrary. So in both pre-senile and senile dementia, Alzheimer's disease uh, is the commonest, and we'll go a little more into Alzheimer's uh, the pathology and so on. But it's important to recognize how important it is, Alzheimer's disease. Next, uh, Lewy body dementia is also now becoming recognized, increasingly recognized as a common cause. Uh, the vascular causes, particularly arteriosclerotic dementia, is again a very important cause both in the senile and pre-senile variety. So arteriosclerotic dementia, usually due to thrombosis uh, of the arteries, blockages, and so on, can cause infarction. So this is sometimes called multi-infarct dementia. Other causes, Pick's disease. Then we have Huntington's chorea. I won't go into too much detail; it will take a long time. But some are interesting, like prion disease, which is a infectious proteinish material, earlier called Kuru or bovine spongiform encephalopathy. It's not very, the whole picture has not been completely elucidated, but they seem to be related to Creutzfeldt-Jacobs disease, a progressive kind of motor neuron disease type of picture. Then we have a condition called normal pressure hydrocephalus, where there is again signs of chronic confusion or intermittent chronic confusion. Another very important cause is Parkinson's disease, and Parkinson's disease again is interesting. Um, Very often it affects subcortical structures, caudate nucleus, and structures uh, in the subcortical area, but even the cortex can be affected, and that's where you get the Lewy body type of dementia. But the manifestations, unlike in other dementias, you may get a very more prominent extrapyramidal side effects. The motor system may be more affected, and they are very sensitive to medications. So this may be way of differentiating Lewy body. Wilson's disease, where you get affection of the liver also, and then other important causes which we have to be aware, particularly because some of them are reversible, space occupying lesions. If you remove a benign tumor, the patient may recover. So it's important to be able to recognize some of these conditions and treat the ones that are amenable to treatment. So cerebral tumors, subdural hematomas, evacuation of the blood clot can be therapeutic. Abscesses can be treated. Tuberculosis definitely can be treated. So these are all treatable. Uh, Post-traumatic dementia. Sometimes people who are exposed to repeated small head injuries, maybe not each individual head injury or episode may not cause a clinical syndrome, but repeated damage like into boxers. Uh, then infection. Earlier, of course, neurosyphilis was very important cause that people saw tertiary syphilis, general paralysis of the insane. But now, currently, HIV is a leading infectious cause, and up to 30% of people towards the end stage may develop what we call a HIV dementia complex. And then we have already mentioned about Kuru, various cerebral vascular disease. We have mentioned about arteriosclerotic dementia, um, epileptic, people who particularly have repeated status. Yeah, there may be residual brain damage. They may have periods of anoxia and so on, can lead to a picture of dementia. So, long-term epilepsy. Metabolic conditions like uremia, liver disorders, when there's failure, or even when you get uh, intermittent abnormalities, they may lead to brain damage. Even in uremia, people who have to undergo dialysis may develop some long-term problems, chronic nature. Myxedema, like the myxedema and other endocrinal disorders, are again very well known. So myxedema is very important and may not be recognized. Milder myxedema conditions, and you may sometimes the clinical picture may be dominated by cognitive changes, slowing, or some memory disturbances, or difficulty in concentration, attention. So it's always worth doing the thyroid thyroid function test as a routine in cases where we suspect hypoglycemia again. When there are repeated hypoglycemia, there may be residual brain damage, and you can get a chronic picture. Alcohol uh, damage to the brain. Alcohol is a neurotoxin, and gradually over the years, people who drink heavily, it accumulates, and finally you may get a dementing picture at the end. Uh, there's a special type of damage when there's thiamine deficiency called Korsakoff psychosis. It affects the deeper diencephalic structures and very prominently memory disturbance. Anoxia of whatever cause, so lack of oxygenation to the brain due to circulatory problems or due to respiratory disease, can all lead to chronic confusion state. And again, as we mentioned earlier, with alcoholism, thiamine deficiencies and other vitamin deficiencies can lead to chronic confusion state. This is a picture of uh, the brain with Creutzfeldt-Jacobs disease. Uh, so they are supposed to have a kind of spongiform encephalopathy, supposed to resemble a sponge, the brain matter. Sorry. Arteriosclerotic dementia, as we said, it is due to affection of the cerebral vessels. Yeah, you may get thrombosis and occlusion of vessels, which then leads to infarction and areas of cellular death. So another name for arteriosclerotic dementia is multi-infarct dementia, and it may result in focal areas of uh, brain death. There may be even softening. There may be small microscopic cavities, sometimes called lacunae, state, or there may be more generalized damage to the brain. And if you look at the artery itself, you'll see the typical arteriosclerotic the process: occlusion, intimal thickening, and plaque formation in the artery, arteriomatous plaques. And as I mentioned, dementia with Lewy body, you get this Lewy body in the cortex, in the cells of the cortex, same as in Parkinson's. Now, the clinical picture again, it is worth emphasizing again and again. it's very similar. Despite all this etiology and we look at the different causes, we are going to have a very similar clinical picture. So, one is the insidious progressive nature. There is a gradual decline, usually, in memory, cognitive functioning, personality, and in social behavior patterns. So, we see this kind of gradual downhill course. Sometimes this is made manifest by some acute episode, for example, death of a partner, or some trauma, mild head injury, or some anoxia due to a heart attack or respiratory condition, or just using some heavy sedative medication. And you might see the full blown picture, which was not recognized earlier because it was an insidious and a gradual onset. People may not have seen the changes or recognize the changes, but this brings it out. And in arteriosclerotic dementia, you can get an epileptic form, meaning like a stepwise deterioration, sudden, like a stroke. They get a stroke, and as they recover a little bit from the stroke, you might find that there is a dementia. There's evidence of widespread brain damage. So these are different clinical uh, presentations, but overall the picture is very similar. Uh, Defects may become global, affecting both the recent and long-term memory as the condition deteriorates. Now, in normal aging, also you can get some memory disturbances, but it is not so widespread. It may be very patchy and mild, while in dementing process, it is widespread, affecting uh, their functioning, and it is very obvious while with normal aging. So sometimes there is a clinical judgment, and you may be called upon to make a decision between normal and dementing process. In the dementing process, one is over time you will see that the deterioration is quite rapid. While normal aging, it may not progress uh, that rapidly, and they retain some fairly reasonable social and personal functioning. So that is another sign. Uh, Other aspects are sometimes called topographical disorientation. Person loses their way in familiar surroundings, like at home. They may go come out of the room and then not be able to find their room, or they may not be able to find the restroom or the bathroom, or they may not lose their way once they leave the house. They may not be able to come back. So these are signs of topographical disorientation, particularly affecting the parietal lobe. Thinking is disturbed, and both qualitatively and quantitatively. Usually, it becomes slow, labored, and improvised. That less and less complex thought is seen. The person finds it difficult to concentrate, attention is poor, and they get tired very easily. So, but we say poverty of thought, very few thoughts, and they all stereotype. They keep repeating the same thing again and again, and they seem to be caught in a constricted world, and very concrete type of thinking of uh, banal, day-to-day matters, and they don't seem to be able to think in an abstract way. Judgment is impaired with loss of insight, except in arteriosclerotic dementia. Uh, yeah, there may be a element of insight, and this may cause some depression. The person recognizes that they are losing their um, capacities. Speech is a reflection of what's going on in the thinking process. So you can get uh, perseveration, you can get poverty of speech, and various types of errors in speech. One characteristic type of uh, sign is nominal dysphasia. Person is not able to name things, and these are usually starting with more uncommon objects, but in time, even common objects they may find it difficult to name, and they may go around the tell you the function of the thing, but they are not able to recall the name. Ultimately, speech becomes incoherent, uh, fragmented, and then they may stop speaking altogether. So the behavior pattern is a reflection of what is going on in the brain, the atrophy and damage. So there may be a gradual loss of interest in what they do, in their motivation, in their drive. They become more and more withdrawn and apathetic. They may not be able to carry out what they are able, what they were doing or what they have the capacity for, even their normal day-to-day care, their responsibilities at home. They may not be able to do, or if they are professional people who are working, you might find that they lose the capacity to at the workplace, and that may be reason why they are asked to retire or they have to terminate their employment. Some of them compensate for this loss by becoming very rigid and obsessional. So they keep diaries, keep to a set pattern, and try to uh, do things in a particular order. And when this gets disturbed, they may get very upset and they lose track of what they are doing. But this is a kind of compensation for the loss that they are seeing. And some may be able to compensate for long periods by adapting these methods. So it's good not to disturb this, to actually, in fact, I encourage them to keep diaries, to keep notes on the wall, reminders of the appointments, cues, so even signs saying where the bathroom is and so on. These are helpful for people who are losing their memory and their brain function. There may be ritualistic coding. They collect all kinds of rubbish that may not be necessary or important. And finally, there may be incontinence, urinary and fecal. And that may be a sign of the end process where they become bedridden, they become emaciated, and they become incontinent. Now, sometimes, as I mentioned earlier, the condition starts in certain areas of the brain. Uh, so you can get focal signs. So you say frontal lobe or temporal lobe, um, the parietal lobe, and so on, depending on where the process starts. Now, it's not very important to go through all this in detail, but just to be aware so that you can make a diagnosis and understand what's going on. So, generally, depending on the area that's affected, you can get focal signs, epileptic seizures rising from that area, or weakness, and so on. And if you look at the frontal lobe, because it's a silent area of the brain, you may not see many signs. There may be just some coarsening of the personality. The person is not the same as before. Uh, there may be some emotional apathy. They may lose their judgment, or they may become disinhibited, and some neurological signs like grasp reflex, motor Broca's dysphasia, and so on. Causes include GPI, earlier time, and various types of tumors or trauma. Motorcycle accidents, you might get trauma to the frontal lobe. And conditions like Alzheimer's and tics seem to affect the frontal lobe. Temporal lobe characteristic is disorders of communication. The temporal lobe is very important in communication process. So when you get temporal lobe affections, you get various dysphasias, particularly sensory Wernicke's dysphasia, nominal dysphasia we mentioned already. Um, Memory may be affected. Temporal lobe is again implicated in memory function. So you may get various memory disturbances, personality changes, particularly if it affects the amygdaloid nucleus that is deep inside the temporal lobe. You may get aggression, irritability, so on, and neurological signs, because the motor tracts may be affected, or the uh, visual pathways are affected. You get contralateral defects in the visual field, or you can get a hemiparesis on the opposite side. Parietal lobe is very interesting type of lobe. When you get affection of the parietal lobe, you get something called asterignosis, where it's cortical sensory loss. They are unable to. They may feel a sensory, but they are not able to identify what it is, or they are not able to put the different information they get together. Disorders of body image, apraxias, in carrying out normal like dressing and so on, and other signs, neurological signs, visual signs, and so on. Now, again, like in acute organic reaction, I would like to quickly go through some of the etiological factors, just to show the wide uh, clinical the uh, causes, the background factors, uh, and to some extent, it is important to know to also to be treated properly. Some are reversible, some can be treated appropriately if the etiology is known, and also helps us to understand various processes that are going on in the brain, and maybe in the future they can design proper, adequate, appropriate treatment uh, with all these new developments in stem cell and implantations and so on. We may be able to treat many of the conditions that we now find untreatable. So generally, when we look at the dementias per se, that is the main focus of the chronic conditions, or the common condition is dementia, and it's now we look at the differential diagnosis, and the important thing is to rule out any treatable cause. So although it may clinically the presentation may resemble a chronic um, confusion state, look for treatable causes like myxedema, B12 deficiencies, subdural hematoma, meningiomas. These are all treatable, and you person can make a full recovery. So I think our primary responsibility is to rule out. Then depressive pseudo dementia, due to depressive illness, particularly in the elderly, they may have signs of cognitive impairment, attention, concentration, and they may complain of memory loss. So it's very important to do proper cognitive assessment and look for signs of depression. And if you treat the depression, they may improve, they may recover. So again, a treatable cause, and so very important to look for depression. Then again, we mentioned about the sometimes a problem between differentiating between normal and pathological or dementing process, and memory this loss may be there in both, but in dementing process it's very marked and very rapid, while in normal aging it is patchy, and the person's normal functioning may be preserved. He may be able to continue to function. Dementia precox is the old name for schizophrenia. So schizophrenia also, particularly chronic schizophrenia, there can be gradual, there can be actually damage to the brain. This has been shown with CT scans and so on. Uh, so you may get a kind of a loss of cognitive function, executive functioning, memory disturbances, and so on with chronic schizophrenia. And important is acute organic reaction. So again, the acute organic reaction may be on top of a chronic dementing process, which becomes clear when you treat the acute. But always uh, look for any acute organic reaction symptoms and causes which can be treated. So it's important to recognize this. So to make the diagnosis, uh, traditionally it was the chronic progression, deterioration in memory, personality, and so on. The long-term loss that we see in their uh, capacity. There may be a family history, as we said, some conditions like Alzheimer's and so on. There may be a strong family history. Then, of course, our mental state examination, particularly the cognitive defects. So you look for the memory, signs of local signs, the various dysphasias, apraxias, and so on, and uh, concentration, attention, intellect, and so on. All these can be examined in the mental state. The mini mental state examination is a good way, very quick and easy way, a questionnaire to see whether there is any cognitive decline. Then physical examination may be also very important, equally important. You may be able to detect localizing signs, some weakness, paralysis, outgoing plantar, or elevated blood pressure, and so on. And again, as in acute organic reactions, you have to do the routine examinations, um, like blood flow, normal full blood count, various endocrinal levels, particularly T3, T4, to rule out myxedema, B12 levels, um, cardiac, respiratory, all these systems will have to be looked at. Then the neuroimaging techniques are very important, and they can even help you to make a diagnosis of brain atrophy, e.g., lumbar puncture of those days. Psychometry is to establish cognitive decline, and nowadays people don't have to do cerebral biopsy, but that was the old way. So wait till after death you make a postmortem diagnosis of dementia. Able measure. Then the modern trend or the modern uh, method that's increasingly being used to treat early dementia is to use drugs targeting particularly the cholinergic system, but even other systems are now being increasingly targeted as more and more research shows the different processes involved. And this has shown that particularly in early and moderate type of dementia you can get marked improvement. So definitely there is a room and there's indication to use these drugs, although they have some side effects. Can be used in the proper way. They have an important role in treatment of dementia. So I will go into some of these drugs a little bit to just show you the what's being done. There's a lot of modern research, and young medical graduates and researchers who are interested. This is the area of the future. There's such a large aging population, and such possibilities of intervening in the aging process to chemically manipulate um, some of the pathways involved, some of the reactions. There is a lot of opportunity, and you might even win a Nobel Prize if you find, say, the cure or way of alleviating conditions like Alzheimer's disease. And new methods like implantation of substances or with a stem cell uh, now research may be able to introduce uh, stem cells with potential to repair or to grow, and so there's a lot of potential, new potential in this area. So just to quickly go through some of the drugs that we are using, the anticholinergic drugs like nonapsil, is an inhibitor, and it inhibits the acetylcholinesterase, which causes the breakdown of acetylcholine. and these can be inhibited within the cell, or once extra cellularly once it's released into the synapse, so that the amount of acetylcholine is increased. This can improve cognitive function. Another drug is galantamine, and here the action is described as uh, positive allosteric modulation, because the action it works through the nicotinic receptors uh, by inhibiting the breakdown of acetylcholine, which is also involved in uh, binding to the receptor, including nicotine. So, when adequate amounts are available, the gate is open, and calcium or whatever is able to go into the cell. So, the allosteric modulation is by changing the configuration of the receptor, so that it can function normally by inhibiting the breakdown of acetylcholine. Another novel substance that is being used now with a slightly different mechanism is it involves a glutamate neuron, and in Alzheimer's the theory is that there is excitotoxicity. Too much of glutamate is released, which causes excessive extracellular substance to go in, like calcium and so on, through the NMDA receptor, which causes free radical formation that may cause cellular death. So, and that leads to memory disturbance. So, you get a kind of excessive glutamate activity, and using memantine in a way reduces or blocks this excessive glutamate activity, leading to uh, normal amount of the ions going in, which can lead to memory memory improvement, and even some uh, neuroplasticity, growth of neurons, or repair. Now, overall, we mentioned again and again, um, like in Alzheimer's disease, there's gradual progression, deterioration, and death at the end. And this may go on for a couple of years, from 2 to 7 years. And in arteriosclerotic dementia, these are kind of epileptic picture, stepwise. So every time you get an infarction, there's a rapid uh, downfall, severe deterioration, and then there may be slight improvement over time. Then again another stroke, another thrombosis, and so on. So you get this stepwise pattern. And in the secondary dementias, they can be reversed. So it's very important to detect these and treat them. Reference, there's no better book than Leishman, which is now gone into, I believe, the fourth edition. Thank you.